Hello everyone, welcome to the second part of the presentation on gestational diabetes mellitus. In the first part of this presentation, we had discussed about the definition of gestational diabetes mellitus, epidemiology, pathophysiology, screening methods, and diagnosis of gestational diabetes mellitus. In the second part, we'll discuss about the management of diabetes during pregnancy, including the management of gestational diabetes mellitus. The management of diabetes during pregnancy consists of pre-pregnancy control and pre-pregnancy counseling, the control of diabetes during pregnancy, and post-pregnancy control. The management approaches consist of dietary consideration, exercise during pregnancy, the determination of blood glucose, and intensive insulin regimen. There is a concept of pre-pregnancy diabetes clinic. Aim of this diabetes clinic is to educate the partners about the risk of diabetes in pregnancy and obtain the maximum cooperation from the partners. Another aim is to obtain optimum diabetes control before conception, identify the time of conception accurately. We need also to check the immune status of the pregnant lady about the rubella, and we have to encourage the pregnant mother about the good general principles of health and hygiene maintenance during the pregnancy. Now let's discuss to a very important topic, that is pre-pregnancy counseling. In this pre-pregnancy counseling, all women of childbearing and pubescent girls are given counseling, and they should also be aware that this pre-conceptional counseling is a very important part of this diabetic care. All pregnant ladies should be aware that maintaining of HbA1c level below 6.5% is the safest alternative during the pregnancy. The women with pre-existing type 1 and type 2 diabetes should also be informed that what are the effects of pregnancy on diabetes, as well as what are the effects of having this diabetes on pregnancy. It is seen that women who have planned pregnancy have better outcome as compared to those who have unplanned pregnancy. The pre-pregnancy counseling consists of understanding the risk of having diabetes in pregnancy to the pregnant ladies, that it can cause perinatal mortality, congenital anomalies, maternal mortality, other diabetic complications, obstetric complication, and inheritance of diabetes in offspring. Apart from that, in pre-pregnancy counseling, it is advises that there is need of frequent antenatal visits and close supervision to the pregnant lady having diabetes. There is requirement of strict blood glucose control, and also the appropriate diet should be given to the pregnant ladies. Apart from that, few other advices should also be followed, like folic acid supplementation and the method of contraception and the importance of contraception during the pregnancy. Now let's discuss about the importance of initial evaluation which should be carried out during the pregnancy among the pregnant women with diabetes. The first one is importance of evaluation of glycemic control, optimizing the glycemic control by self-monitoring of blood glucose and educating the woman about the having diabetes in pregnancy, adjustment of insulin regimen if required, checking of dietary pattern and dietary preferences of the ladies, and checking the level of HbA1c during pregnancy. The second important evaluation is preconception targets. We must set the target of the blood sugar level. The preprandial blood sugar level should be less than 90 mg per deciliter. The postprandial blood glucose should be less than 120 mg per deciliter, and HbA1c level should be in non-diabetic range, that is less than 6.5%. What is the role and importance of exercise during pregnancy? The planned physical activity of 30 to 45 minutes per day is recommended to the pregnant ladies. It should also complement the dietary recommendations along with the exercise. The activities which can increase the blood pressure level should be avoided by the pregnant ladies. These activities can be lifting heavy weight, pushing heavy objects, etc. It is seen that upper body resistance training has effect on blood glucose level as it reduces the blood glucose level in the third trimester. So it is advisable in third trimester. If obstetrician has advised not to do physical activity or he has restricted for the physical activity, then this advice should be followed very strictly by the pregnant ladies, and they should adhere to his advice. This table shows the dietary recommendation and daily nutritional requirements of patients with diabetes during pregnancy. The calorie should be consumed as 35 to 45 kilocalorie per kg ideal body weight, or the calorie should be consumed 300 kilocalorie per day above the non-pregnant needs. Carbohydrate should be consumed as 200 gram per day. It should consist of minimum 45% of the calorie requirement, or carbohydrate should be consumed as 50 gram per day above the non-pregnant needs. Fat should be consumed as 40 to 60 gram per day, and it should consist of 35% of the whole calorie requirement. Iron should be given as 27 milligram per day, folic acid 570 microgram per day, calcium 1000 milligram per day, and vitamin B12 should be consumed as 2.75 microgram per day during the pregnancy. Now let's discuss about the monitoring of blood glucose during the pregnancy. The self-monitoring of blood glucose SMBG is a very important step in glucose monitoring, and it should be performed several times in a day. However, the urine glucose monitoring is not found to be much reliable, and it has low threshold on diagnosis of gestational diabetes mellitus. The urine ketone monitoring is very important, very useful in detecting insufficient calorie intake or carbohydrate intake among the pregnant lady. HbA1c can be an important indicator of glycemic control. For lab monitoring till 28th week, it should be done once in a month. From 28th to 32 weeks, it should be performed once in 2 weeks, and after 32nd week, it should be performed once in a week. And the monitoring of blood glucose should be performed more frequently in case the pregnancy is related with the high risk. Now let's discuss about the importance of measuring fetal abdominal circumference, which can be used as a marker of metabolic control of the blood sugar level of diabetes during the pregnancy. Various studies have suggested that the measurement of fetal abdominal circumference and liquor volume by ultrasonography during the second and early third trimester is very important in guiding the management decision of delivery of the pregnancy, and it should be repeated in 4 weeks. It is seen that the fetus of diabetic mothers have disproportionate increase of the fetal abdominal circumference as compared to other USG biometric parameters, which includes biparietal diameter, the head circumference, and the femur length. And this increase of fetal abdominal circumference is due to the increased fat deposition in the subcutaneous tissue and increased glycogen level in the liver of the fetus, and it is due to hyperglycemia in the mother. The disproportionate increase in the abdominal circumference of the fetus, which is more than 75th centile as compared to the other markers, other measurements, which includes the bipyramidal diameter, head circumference, and the femur length, suggest that there is suboptimal glucose control, glycemic control in the mother during the pregnancy. Now let's discuss about the obstetric management during the first trimester. What are the important steps we should follow during the first trimester? We should take a proper menstrual history and calculate the date of last menstrual period. Blood pressure monitoring is very important during the first trimester. We should record the weight, and we should also, there is requirement of appropriate dietary advice to the pregnant ladies. The optimum glycemic control is very important during pregnancy during the first trimester, by which can be done by the teaching the pregnant lady about the home glucose monitoring, the importance of insulin therapy. HbA1c level should be recorded. Renal function tests should be carried out, including the creatinine clearance and daily protein excretion monitoring. The baseline ophthalmic examination is required. Counseling for the pregnant lady about the risk of congenital anomalies is also very important. Ultrasound should be performed to check for the fetal viability. Apart from that, it is also important for dating of the fetus and to check of development of any anomalies in the fetus. Now coming to the obstetric management during the second trimester, it includes blood pressure monitoring, weight and dietary recommendation, weight measurement, the monitoring of glycemic control, whether there is a need of increase insulin dosage during the second trimester, recording of HbA1c level, measurement of renal function test, including creatinine clearance and dairy protein excretion as in first trimester, ophthalmic examination. The serum fructosamine examination can be very useful as a measurement of short-term glycemic control. The ultrasound should also be performed in the second trimester for checking any major malformations, fetal heart examination, the growth of the fetus and the measurement or assessment of liquor volume. We need also to check for the complications of pregnancy. It can be preeclampsia, the polyhydramnios, any urinary tract infection or any vaginal candidiasis, which is a kind of fungal infection of the vagina. Now coming to the obstetric management in the third trimester of pregnancy, this includes blood pressure monitoring, the calculation of weight and diet, monitoring of glycemic control. It is seen that the insulin dosage increases in 34 to 36 weeks, then it plateaus and there is small decline of insulin dosage towards the term. Assessment of renal function, including the creatinine clearance and daily protein excretion, the frequent ultrasound to assess, to check for the macrosomia and for the liquor volume. Check of maternal complication should be done in third trimester to check for any presence of preeclampsia or preterm labor. Now discussing to the obstetric management in general. While planning the timing of delivery, the obstetrician should always balance the risk associated with the prematurity with waiting too long, which can cause macrosomia and fetal demise. It is seen that if GDM is diet treated, then many of the obstetricians they allow to continue the pregnancy till 40 weeks. However, if the pregnancy is insulin treated, if insulin treatment is being given to the patient, then it is not allowed beyond 38 completed weeks. About the mode of delivery, it depends upon the obstetric consideration. However, we should note that the diabetic itself is not a indication for cesarean section. When there is early delivery is contemplated, then we should also keep in mind about the risk of iatrogenic prematurity as well as about the respiratory distress syndrome, as it is very common in early delivery prematurity. It is noted that antenatal use of systemic steroid which is usually used to accelerate the fetal lung maturation, not contraindicated in a mother with diabetes. Now, coming to the management of diabetes in pregnancy. So, the woman with diabetes during pregnancy should not attempt weight reduction during the pregnancy. However, they should always avoid excessive weight gain during the pregnancy. For any obese woman, there should be calorie restrictions, and it should be around 30 to 33% of calorie restriction should be there. It means the woman should consume about 25 calorie of energy per kg per day should be consumed. In preconceptional supplementation, for preconceptional supplementation, the folic acid should be given in a dose of 0.4 to 0.8 mg per day. Whenever we are initiating exercise during the pregnancy, always we should start the exercise program gradually with moderate exercise. It should always be in conjunction with self monitoring of blood glucose to avoid hypoglycemia. It is seen that this exercise helps in lowering the maternal glucose concentration, and it is very effective in preventing the progressive obesity in such women. The insulin is the drug of choice in any form of diabetes in pregnancy. In pre-existing diabetes, the insulin requirement is assessed that in first trimester, the insulin should be given at a dose of 0.9 unit per kg per day. In second and third trimesters, the insulin requirement is approx 1.2 unit per kg per day, which can go up till 1.6 unit per kg per day. The insulin dose requirements in case of GDM have been noticed to be much lower as compared to preconceptional diabetes. The regular insulin, NPH, Lispro, Aspart and Detamir are approved for use in pregnancy. However, in case of glulisin, no data is yet available. This insulin glargine has not been approved for use in pregnancy, but the women who are already in treatment on glargine prior to conception should continue with glargine only during the pregnancy, as no adverse effects have been noted while use of glargine. In case of insulin degludec, the data are insufficient in respect of use in pregnancy. The oral anti-diabetic agents should be discontinued as soon as the pregnancy is confirmed, and we should start the pregnant woman with diabetes on insulin regimen. However, there is an exception in case of metformin. If the metformin has been initiated preconceptionally, it should be continued for the rest of the pregnancy. Now the question arises, when the insulin should be started? When we have already given 2 weeks of medical nutrition therapy to the patient with diabetes, the SMBG, self monitoring of blood glucose readings, are fasting if it comes more than 90 mg per deciliter, and the postprandial glucose level comes more than 120 mg per deciliter, then we should considering about the insulin dosage. The DIPSI recommends for the measurement of 2-hour postprandial glucose level. However, the American Diabetes Association, they recommend the option of testing the blood glucose level after 1 hour of consumption of the glucose. It is seen that in case of gestational diabetes mellitus (GDM), the once daily dose of insulin is sufficient. That should be usually given before the breakfast. But if the fasting blood glucose comes high, then we can consider to give the night dose also. It should be added. In case of GDM, the pre-mixed insulin is the most convenient form of insulin dosage. However, in case of pre-existing type 1 or type 2 diabetes, the most patient of such diabetes need 3 injections of insulin daily. However, sometimes this number of doses can increase up to 4 to 5 injections per day. The single rapid acting or regular insulin regime is usually sufficient to treat the gestational diabetes mellitus, and usually this dose is given in the morning as compared to the evening. As I have already described that pre-mixed insulin is more convenient to give in GDM. So what must be the glycemic targets in pregnancy? It is seen in various studies that we should consider to maintain the mean plasma blood glucose of 105 mg per deciliter, as it ensures the optimal fetal outcome, and this level of 105 mg per deciliter can be achieved by keeping the fasting blood glucose level around 90 mg per deciliter and the postprandial blood glucose level less than 120 mg per deciliter. Coming to the intrapartum management of diabetes, especially during the labor, it is seen that many women with GDM or pre-existing type 2 diabetes mellitus, they will need insulin during the labor. If the insulin is needed during the labor, then it is best that we should start the patient on glucose as well as on insulin infusion, and 5 units of insulin is added with 5% dextrose drip, and the drip rate should be maintained at 100 ml per hour. This will deliver approx 5 grams of glucose as well as 1 unit of insulin per hour. If the insulin requirement is high, the more insulin can be added to the drip. In many patients with GDM and some with pre-existing type 2 diabetes mellitus, usually the insulin will not be required during the labor. Coming to the insulin management during the labor as well as delivery, usually the intermediate acting insulin dose is given at bedtime. The morning dose of the insulin is withheld on the day of delivery. The intravenous infusion of normal saline is started. Once there is an active labor started or blood glucose level falls to less than 70 mg per deciliter, then we will shift the infusion from saline to 5% dextrose to maintain the blood glucose level. The glucose levels are checked early using glucometer. Regular short acting insulin is administered intravenously if glucose level are going up or more than 140 mg per deciliter. Coming to the management of diabetes complications, if retinopathy has already been developed, it can worsen during the pregnancy. For that, photocoagulation can be needed. If nephropathy is already developed, then it can also worsen during the pregnancy, especially if creatinine clearance is very low preconceptionally. For this, we should strictly control the blood pressure. Now coming to the key to successful management of diabetes, which is complicating pregnancy. So for that, we should focus on the preconceptional counseling and intensive therapy regimes if required. We should follow the contraceptive method if the tight blood glucose control is not being achieved. Tight glucose control is maintained throughout the pregnancy. The timing of delivery should be carefully planned depending upon the glycemic level of the pregnant lady. The meticulous follow-up after delivery is also very essential in such cases. The vigilance, surveillance and management of diabetic complications should be focused. For better outcome, successful outcome, there should be close correlation between the diabetologist as well as the obstetrician. How the diabetes can be prevented during the pregnancy? The postpartum follow-up of GTT is mandatory for all cases of GDM 6 weeks after the delivery. In case the pregnant lady is with normal glucose tolerance, then we need to reassess the glycemic condition after the 3 years interval. In case the woman is pre-diabetes, whether she is with impaired glucose tolerance or with impaired fasting glucose, then annual assessment of the glycemic condition to be assessed. And apart from that, the intensive lifestyle modification is required for such women. If the woman is already having type 1 or type 2 diabetes, then we need to treat the woman for diabetes. For all GDM, gestational diabetes mellitus cases, lifestyle modification, mainly the weight reduction, should be focused. What should be the postpartum management plan for such gestational diabetes mellitus cases? So, this plan should include for addressing the glycemic management and surveillance, the nutritional management, the prescription of contraception, planning of future pregnancy, focus on lifestyle changes. Such gestational diabetes mellitus cases should be followed up for the oral glucose tolerance test at after the 6 weeks postpartum. If the 6 weeks postpartum OGTT is missed, then OGTT should be performed after the 6 months and 1 year postpartum duration. Coming to the conclusion of this presentation, the good control of diabetes during pregnancy can improve the intrauterine environment. It can reduce the risk of macrosomia and minimize the future risk of diabetes in the offsprings. Lifestyle modification in women with prior gestational diabetes mellitus can play or prevent onset of type 2 diabetes in their later life. Thank you so much for watching this video. Please like and share this video with others.